Okay. We'll go ahead and get started. I know that a few others might be joining us in the next few minutes. Looks like we have a good audience to start with. This is the first of the 2024 talks in our hepatology and liver transplantation webinar series, for which I'm the course director, and I'm really excited to kick off our 2024 series today. The topic of today's talk is updates in management of decompensated cirrhosis, which was sort of intentionally vague so that I could specifically hone in on a specific topic. So the topic that we'll discuss today or focus on is pre-procedural and pre-surgical risk assessment in patients with cirrhosis. I do want to just, before we get started, point out that you can actually put in your questions in the chat or Q&A, and Lindsay Carter, who's one of our excellent administrative assistants, has been helping put this together, and she's put information in the chat regarding how to do that, as well as information regarding CME and nursing credit. So let's get started. So again, this is a webinar series that does provide free CME. This is the information for that. It does provide one AMA PRA Category 1 credit. I have no relevant financial relationships to disclose, and also none of the planners, faculty, or individuals in control of this content have any relevant financial relationships to disclose. Evaluations for this talk will be provided electronically using SurveyMonkey with the ability to claim CME credit. So at the end of the course, you can visit the link below as well as the QR code. This information is on the website, as well as I will give an opportunity to share this slide again at the end of the talk. In addition, this talk provides nursing credit as well, and this information that you see on this slide is also provided on our webinar website. Okay, so I mentioned that this is the Hepatology and Liver Transplant webinar series for 2024. This is the first talk today. I just want to mention right now that we have several exciting topics in the series later in the year as well. My transplant surgical colleague, Dr. Baba Baikoff, is giving a talk in May on the updates in liver donation and liver transplant surgery. My colleague, Dr. Foreman, is giving a talk in July on the updates in management of cholestatic liver diseases, an area in which she is certainly an expert. My colleague, Dr. Norvell, is giving a talk in September on the updates in management of alcohol-associated liver disease. And Robin Bricker-Ford, who is a pharmacist who works in our clinic, is going to give a talk on updates in viral hepatitis in the outpatient setting. There'll be more reminders as the year goes on, but these are the topics for this year, born out of feedback from prior years' talks. And so certainly if there are topics you'd like to hear in the webinar series in future years, certainly that is something, that is feedback that we would like to hear. So learning objectives for today. As I mentioned, we're going to focus on pre-procedural and pre-surgical risk assessment in patients with cirrhosis. Number one, we'll review classifications of decompensated cirrhosis, including the MELD score. Number two, understand the clinical utility of coagulation tests in patients with cirrhosis. Three, access practice guidelines related to the management of pre-procedural bleeding risk in patients with cirrhosis. And lastly, we will evaluate risk prediction models for post-operative mortality in patients with cirrhosis. I want to start by sharing what is admittedly a busy slide, but it's a figure that was included in a recent AASLD guideline on portal hypertension just published in October of 2023 in the Journal of Hepatology. It is a really great figure actually for teaching purposes, and so I'm just sharing it here, and you can reference the AASLD guideline that I mentioned that reviews decompensations related to cirrhosis and has a nice figure showing the pathophysiology of, for example, hepatic encephalopathy, variceal bleeding, ascites, and hepatorenal syndrome. I think it's a really helpful slide that goes over the complex pathophysiology in these patients. So when we talk about compensated cirrhosis and decompensated cirrhosis, there are multiple ways that we can approach this conversation. First of all, this is a figure, again, from the same guidelines that gives a bit of a framework in terms of how we might think of patients with compensated cirrhosis and decompensated cirrhosis. In terms of compensated cirrhosis, lower risk certainly of decompensation. You can notice that on the left side of this figure, you may have a lower portal systemic gradient. As that increases and as fibrosis increases, you have a higher risk of decompensation. For example, you may have endoscopic features of varices but haven't had a clinical decompensation. There is about a 12 to 15% annual risk of varices bleeding in patients who have not bled before. And so certainly the presence of varices may be a sign of decompensation to come. The risk of death shown at the bottom in this rough figure certainly increases once patients have decompensated cirrhosis, such as varices, ascites, and then increases even further with additional decompensation. Hospital mortality with complications of cirrhosis is significant. This might be an area that we become jaded to just because of how frequently we see hepatic encephalopathy, ascites, and varices, for example, the classic clinical decompensations associated with cirrhosis. In this retrospective study of patients in Spain from 2003 to 2010, looking at discharges of patients with cirrhosis, you can see the significant in-hospital mortality of these conditions, as high as 60% with hepatorenal syndrome, 11% with varices, and 8.9% with ascites, just as examples. This is also a helpful staging system. When patients have cirrhosis, so they have stage 4 fibrosis already by definition, we can think of this other staging system that was provided by D'Amico in this paper in 2006 of stages of cirrhosis 1 through 4. And you can see that this is a helpful tool to discuss with patients when they commonly ask, well, what is my chance of dying from my liver disease? This is a helpful tool to think about where they are on this spectrum in terms of their stage of cirrhosis, whether they're stage 1 or 2 or compensated, or stage 3 or 4 decompensated. And you can see on the left that no varices, no ascites, and stage 1 compensated cirrhosis has a 1% risk of death at 1 year, as opposed to almost 60% at stage 4, with bleeding plus minus ascites in that condition. Looked at another way, survival in patients with compensated versus decompensated cirrhosis. You can see in the blue bars a much higher 1 and 2 year survival of 90 to 95% in these patients with compensated cirrhosis, drastically decreasing to 50 to 60%. We know that the patients with ascites, generally speaking, have an approximately 50% mortality risk at 1 year across all age groups. So how else can we classify severity? Well, there are many scoring systems related to classifying the severity of cirrhosis. You may have heard of the Child-Turcotte-Pugh score. The Child-Turcotte score was developed in the 1960s, and then Dr. Pugh modified it in the 70s and added his name to the end. So hence we have the Child-Turcotte-Pugh score that classifies patients with cirrhosis as class A, B, or C. Roughly speaking, as the class advances from A to C, signifies more decompensation. These are the factors that go into the Child-Turcotte-Pugh score: encephalopathy, which can be somewhat subjectively graded, ascites, and then objective measures of bilirubin, albumin, and prothrombin time. Prior to the development of the MELD score, the Child-Turcotte-Pugh score was the basis in many parts of the world for listing for liver transplantation. 3-month mortality based on the Child-Turcotte-Pugh score certainly increases from A to B, and then significantly from B to C. You can see that that scoring system at the bottom is based on points given to those 5 parameters that I mentioned earlier, and you have about a 40% 3-month patient mortality in a Child-Turcotte-Pugh class C patient. I think we're all familiar at this point with the MELD score, and I'll touch on a little bit more on the MELDs in the coming slides. But the MELD score, which was developed in the 90s to predict mortality in patients undergoing a TIPS procedure, was then adopted in 2002 as the foundation of the liver transplant allocation system in the United States because of its discriminative ability to predict 3-month patient mortality, specifically for patients on the waiting list for transplant. And you can see here in a famous table from a 2003 paper in gastroenterology, the increasing mortality with an increasing MELD score from less than 9 on the left to greater than 40 on the right. I think we're all familiar with this graph as well, that 3-month survival drastically decreases, especially beginning with a MELD score of 25, and approaches a near 0% 3-month survival with MELDs over 40. Shown another way, a MELD of 40, roughly a 90% risk of dying within 3 months. I do want to mention that the MELD score has some nuances that are worth noting here. 90-day mortality here shown with or without moderate ascites across the MELD spectrum, reflecting the fact that the MELD can underestimate risk of death in patients with even moderate ascites. And so you can see here that a patient with moderate ascites and a MELD of 11 has an equivalent risk of death as patients with no or small ascites and a MELD of 16. So another 4.7 MELD points in that example would adjust for an observed increase in mortality for patients with a MELD under 21. There are several talks that we gave last year in this webinar series. All of these videos are on our webinar website, including talks on living donor liver transplantation. And you can see one talk there in November on liver transplantation evaluation. I'm pointing that out because more on the MELD score and how we think about evaluation for transplant as it relates to the MELD score are discussed in many of these talks from last year. Out of the scope for today's conversation, certainly, but I do want to just point you in that direction if you're interested in hearing more about how we approach the MELD score. I do want to mention before we go into risk assessment, because it's important to understand our current MELD system a little bit more, that for many years we've been aware of limitations related to the MELD score. The creatinine is a factor that goes into the calculation. And certainly, prognostic impact of impaired kidney function in cirrhosis is well known, but the use of serum creatinine as a surrogate marker of renal function is inaccurate, first of all. And in addition, women who on average have a lower muscle mass have lower serum creatinine than men for the same degree of renal function, which negatively impacts their MELD score. And as a result of that, there was a sex disparity for many years. There has been a sex disparity for many years with the MELD score, with females having a decreased odds of liver transplantation within 3 years of listing compared to males. And in addition, females are more likely than males to die waiting for transplant or be removed from the waiting list for being too sick for transplant. There are other limitations. The serum sodium certainly can be manipulated with diuretics. The INR measurement varies according to a variety of factors and can be sort of artificially elevated by having a patient on a vitamin K antagonist, such as patients with portal vein thrombosis, and they may be therefore artificially over-prioritized on the liver transplant waiting list. The original MELD score was also developed when chronic hepatitis C was the leading indication for liver transplant, and those patients tended to have a higher bilirubin level at the time of listing. Now, with increases in MASH-related cirrhosis, the weight given to bilirubin has been questioned. And so, essentially, there have been more changes in the last year related to the calculation of the MELD score. There's been addition of 2 new variables, current sex as well as albumin, and updates in the coefficients for the existing variables for the reasons I mentioned. So the variables are sodium, bilirubin, creatinine, and INR. There are interaction terms that were introduced into this system between the bilirubin and sodium and between the albumin and creatinine. Essentially, the we're often asked if the MELD 3.0 is how we now allocate patients on the allocate organs on the liver transplant waiting list. So yes, the MELD 3.0 score is now officially adopted nationwide as the primary allocation system for liver transplant. That is the equation, just for reference sake, but certainly that is not something you would ever have to know or reproduce. But I do want to mention that the MELD 3.0 does better predict candidate waitlist mortality, hence the adoption nationwide, compared to the prior MELD sodium. Basically, if we had been using MELD 3.0 in a retrospective modeling study that was done, we would have had fewer waitlist deaths in the preceding years. Each year, it's worth noting that 20% of patients awaiting a liver transplant in the United States die or become too sick for transplant, and this demonstrates a severe shortage of donors and emphasizes the need to increase the donor pool. Certainly, consideration of living donor transplant, which is a procedure that we uniquely offer here in Colorado. So I want to now sort of switch back to the main topic today. We have, again, so far discussed a little bit about the scoring systems of how we consider decompensated cirrhosis. We talked about the stages. We talked about classification systems such as the Child-Turcotte-Pugh and the MELD score. But now I want to get back to these practical questions that we're faced with when we're trying to assess risk in these patients. I think we've all been asked these questions in our clinical practice. So can my patient, excuse me, with cirrhosis undergo a paracentesis? Their INR is high after all, so would it be safe? Get a tooth extraction, have a polyp resected during a colonoscopy, undergo a cardiac catheterization, have a cholecystectomy, get a knee replacement, have an umbilical hernia repair. I think frequently we hear from patients, well, I saw a surgeon for one or more of these issues, and they said I can't have surgery because, quote, I'll bleed out. So how do we approach this? Well, first of all, there are many types of bleeding in patients with decompensated cirrhosis. It's not as simple to say that there's one mechanism causing bleeding in these patients by any means. First of all, you can think of dental bleeding can be potentially related to trauma as well as hemostatic failure. There's bleeding from puncture sites, mucosal bleeding and bruising related to clot weakness and breakdown. There's portal hypertensive bleeding related to bleeding from esophageal varices. Portal hypertension contributing to gastropathy, which is another form of bleeding related to portal hypertension, less so dependent on factors such as pressure and size of, for example, and diameter of varices, which are factors that lead to bleeding in those situations. And then there's bleeding from mechanical insult and trauma. Those are bleeding related to procedures, such as a paracentesis, incisions, and trauma, for example. So first of all, safety of paracentesis. Well, first of all, 85% of ascites in the United States is secondary to decompensated cirrhosis. 71% of those patients, perhaps not surprisingly, have an abnormal prothrombin time and therefore an abnormal INR. The key point here is that coagulation tests don't reflect the real risk of bleeding in cirrhotic patients, traditional coagulation tests, I should say, and I'll talk more about that in the coming slides. It's also important to remember for a paracentesis that serious complications are unusual, less than 1 in 1,000, and there's no data-supported cutoff of coagulation parameters. So let's dig into this a little bit more. So assessing bleeding risk by traditional coagulation methods. Well, the most traditional method that we have to assess bleeding risk in most cases at this point is the INR. This slide is adapted from a presentation that was given at the AASLD liver meeting by Dr. Northup in 2023. But there are now dozens of studies affirming the lack of utility of an INR in accurately predicting procedural bleeding risk in liver disease patients. So there's a lack of utility of the INR. You can see here in the list of publications I mentioned, these are studies showing the lack of utility of the INR for these procedures specifically as they relate to liver disease patients, including liver biopsy, paracentesis, colonoscopy with polypectomy, dental extractions, to coronary artery catheterization. So more on this all-important INR, or what could be called the misunderstood coagulopathy. So INR, as a reminder, is a ratio of the patient's PT, or prothrombin time, as compared to a laboratory normative prothrombin value. And it was designed initially as a method of monitoring individual patients' response to anticoagulation therapy with a vitamin K antagonist, such as warfarin. And certainly that is how we commonly use INR. It's the most common indication to monitor an INR. Somebody on warfarin for whatever the indication is, a DVT, atrial fibrillation, whatever it is, usually targeting an INR goal of 2 to 3. But with patients in cirrhosis, and I want to focus your attention on the second column here for now, there are simultaneous changes that promote bleeding and changes that promote clotting. And in fact, it's important to remember that unlike being on warfarin, where you're anticoagulated specifically as a vitamin K antagonist, and therefore have low levels of vitamin K dependent factors, in patients with cirrhosis, because of synthetic dysfunction, these patients have low levels of factors that promote bleeding. You can see that on the top part of the graph in the table in the second column. But they also have decreased levels of proteins that promote clotting, such as protein C, protein S, antithrombin. This is in the context of many other physiologic changes. So patients have low platelets that may promote bleeding, but they also have elevated levels of von Willebrand factor. These are platelet factors that promote clotting. Other changes, balancing out fibrinolysis, again, on one side promoting bleeding, one side promoting clotting. And so what you have in cirrhosis, unlike a patient on warfarin, where they are truly anticoagulated because of changes that would promote bleeding alone, a patient with cirrhosis has a rebalanced physiology. So you have a decrease in synthesis of procoagulants, decrease in anticoagulants, decrease in platelets, and then an increase in platelet adhesion molecules. And so you can sort of see this a little bit on the left. You've got a normal balance of between clot formation and clot breakdown, an admittedly simplified view of a very complicated process. But the balance of liver disease, while it may be a little bit more fragile or tense on that fulcrum there, it's a balance that results in hemostasis, actually not too dissimilar from a normal balance. And just put into words again, the liver is responsible for the synthesis of many of the procoagulant and anticoagulant proteins responsible for maintaining hemostasis. In most cases, a rebalancing occurs, and the vast majority of chronic liver disease patients achieve that hemostatic equilibrium. So you may have heard or be told or have been advised by others or proceduralists, well, we need the INR under 1.5 in order to safely do this procedure. There's been wide acceptance of this despite no guidelines recommending it. So someone might say, well, I'll do the procedure, but this patient needs an INR under 1.5. So just to be safe, maybe we should give FFP. What would happen with that approach? Well, prophylactic transfusions may expose the patient to increased risks of adverse events, such as transfusion reactions, transfusion-related acute lung injury, exacerbation of portal hypertension as well as a result of the transfusion. And studies show that these prophylactic transfusions provide no protective effects. It's also worth pointing out that despite the notion of auto anticoagulation, meaning, well, their INR is 2.4 related to the liver disease, they must be auto anticoagulated. It's not really true. We know that just logically from clinical practice that patients with hepatic dysfunction are not protected in any way against the occurrence of venous thromboembolism. They certainly still get DVTs. They get other thrombotic events, such as a portal vein thrombosis, despite the quote unquote high INR. So this is an AASLD guideline that was published in 2021, which is helpful actually for review if you're interested on a number of topics, including vascular liver disorders, management of portal vein thrombosis, which is another topic outside of the scope of today's talk, and then specifically as relates to what we've been discussing, procedural bleeding in patients with liver disease. And so a quote from this guideline, this is based on expert summary of evidence, is that due to the conflicting data in the literature, current guideline recommendations from the AASLD do not suggest a specific INR or platelet cutoff where pre-procedural bleeding risk is reliably increased. The AASLD does not recommend routine pre-procedural correction of INR, platelets, or fibrinogen. Of course, in reality, it's worth acknowledging that determining procedural bleeding risk is complex. It requires collaboration between specialists, discussion on nuances of the procedure that may increase bleeding risk beyond what we know from data and guidelines. And so it certainly requires a multidisciplinary conversation between a gastroenterologist or hepatologist and a proceduralist in these situations. It's also worth thinking about the obvious fact that not all procedures are the same, and therefore not all procedures have the same baseline bleeding risk in a non-cirrhotic patient. So some procedures are considered low risk and some are high risk. And for the purposes of this talk and these guidelines from 2021, high risk is considered, a procedure is considered high risk if the baseline bleeding risk is just based on available data of that procedure is felt to be over 1.5%. And so the team that put together these guidelines classified procedures into low risk and high risk. And I think it's sort of helpful to have these conversations with patients if they have a specific procedure that they're considering. So paracentesis, thoracentesis, as you can see on the left side, low risk versus a liver biopsy or a central nervous system procedure or a TIPS would be considered higher risk, just as initial examples. These are other procedures considered low risk on the left, high risk on the right. For example, colonoscopy, including mucosal biopsy on the left, but endoscopic polypectomy on the right, considered high risk just because of the baseline bleeding risk considered to be over 1.5%. So do we have more helpful tests to assess pre-procedural bleeding risk? We certainly do. And many of you or watching this video may be familiar with this concept of viscoelastic testing or thromboelastography, more commonly referred to as a TEG scan. So without getting too caught up in the scientific details of how this is done, I want to explain a little bit about what TEG is and why it's more helpful than just looking at the INR. So first of all, just how it's done in a simplified explanation. So a small sample of blood is taken from a patient. It's then rotated sort of several times through a minute. I believe it's 6 times a minute, which basically imitates sluggish venous flow and activates coagulation. This is done around a thin wire probe around which the clot forms, and that's used for measurement of various factors that reflect speed and strength of clot formation, and it's typically done by a computer. So 4 values that represent clot formation are determined by the test. There's the reaction time, or the R time, the K value, the angle, and the maximum amplitude. Just briefly, what those mean: the R value represents the time until the first evidence of a clot is detected. The K value is the time from when the clot is detected until it reaches 20 millimeters, and this represents the speed of clot formation. Okay. The angle is the tangent of the curve made as the K is reached and offers similar information to the K. And then the maximal amplitude is a reflection of the clot strength. So this is a well-studied mechanism of assessing risk of bleeding in patients with cirrhosis. This study, again, you can see the title here, published in Hepatology, Thromboelastography Guided Blood Product Use Before Invasive Procedures in Cirrhosis with Severe Coagulopathy. This was a randomized controlled trial. You can see that on the left part of the table is the TEG group, meaning they used thromboelastography, that process I just described, to guide whether patients should get blood product before procedures. And then there was the standard of care group. So whatever the physicians taking care of the patients felt was appropriate. You can see here that in the TEG group on the left, blood product requirements were significantly lower than patients in the standard of care group. Total amount of FFP used, significantly lower, and total amount of platelets used, which is the fourth line, 6 units versus 78 units, significantly lower in the TEG group. So this showed that using the TEG decreased the amount of blood products we were given, but was there any difference in outcomes? Well, no, there wasn't, meaning there were more products given in the standard of care group with no change in the outcome. So the mean INR was the same, the mean platelet was the same, and procedure-related bleeding risks and transfusion reactions were not different between the two groups. And in fact, there were no, out of the 30 patients in this study, no procedure-related bleeding and no transfusion reactions in the TEG group. Again, supporting the use of thromboelastography if available for these patients. This is another study from 2021. This looked at 80 patients admitted for decompensated cirrhosis, no bleeding noted on admission. These 80 patients underwent 72 invasive procedures total during their hospitalization, and 7 of these patients had procedure-related bleeding. Okay, 3 of them were major bleeding. All 3 with major bleeding after procedures had a baseline platelet count greater than 50. So despite what is commonly used as a cutoff for platelets before a procedure of 50,000, these patients with major bleeding still had a platelet count over 50. But importantly, all of those major bleeding patients had a TEG maximum amplitude. I mentioned that that's one of the factors that's measured on a thromboelastography of less than 30 millimeters prior to the procedure, suggesting that a maximum amplitude on the TEG of less than 30 may be associated with major bleeding in patients undergoing procedures when they have decompensated cirrhosis. What about in the setting of active bleeding? So what we've talked about so far are trying to assess pre-procedural bleeding risk when there is no bleeding at the start. Now we have a common decompensation, like we discussed earlier, a variceal hemorrhage. Should these patients get transfused with blood products, specifically FFP, fresh frozen plasma, to lower their risk of ongoing or recurrent bleeding? So this was published now over 10 years ago in the New England Journal, but similar to prior landmark studies looking at restrictive versus liberal transfusion of red blood cells. In this study, looking at fresh frozen plasma in patients with cirrhosis, the liberal strategy group had a significant increase in portal pressure during the acute variceal bleeding, and actually may have accounted for a higher rate of further bleeding with the liberal strategy. So essentially, giving FFP in this situation actually led to more bleeding because of the increased plasma volume from FFP given during the setting of variceal hemorrhage. This is another guideline that I want to highlight. We've mentioned a couple of guidelines so far from the AASLD. That's, again, the American Association for the Study of Liver Diseases. That's the main governing body of the management of liver disease in at least the Western Hemisphere. And this was a guideline in 2016 on portal hypertensive bleeding and cirrhosis, where that topic of management of variceal hemorrhage is discussed in further detail. From those guidelines regarding correction of coagulopathy, randomized controlled trials of recombinant factor 7A have not shown a clear benefit, and therefore correcting the INR by the use of fresh frozen plasma or factor 7A is not recommended, particularly given that the INR is not a reliable indicator of coagulation status in cirrhosis. No recommendations can be given regarding platelet transfusion in patients with variceal hemorrhage. Okay, so we've talked a little bit about procedures, bedside procedures, such as paracentesis, thoracentesis, the same data would apply. But can patients with cirrhosis undergo non-transplant surgery? Dr. Mahmood, who's a hepatologist at the University of Pennsylvania, actually gave a talk on this at the liver meeting in 2023. And the crux of his talk was that this is a two-way street. So cirrhosis impacts surgical risk, surgery impacts stability of cirrhosis. And Dr. Mahmood and his colleagues have published in this area quite significantly, and I'm going to go over some of their data. This is a publication from 2021 in Hepatology, Novel Risk Prediction Models for Postoperative Mortality in Patients with Cirrhosis. They looked at a national VA retrospective cohort of 3,785 patients undergoing over 4,700 surgical procedures, and they compared available risk scoring systems to predict postoperative mortality. Now, it's important to note, first of all, before we talk about scoring systems for these patients, that various factors impact their postoperative mortality. You can see on the top, I'll highlight just a couple of points on this graph. On the top left, you can see that their ASA status, as determined by an anesthesiologist, as expected, impacts their survival. So as the ASA grade increases, their survival decreases. This is in line with all other data related to the ASA scoring system. But perhaps most notably here is the top right. So it's important to note that the type of surgery impacts postoperative mortality. You can see, for example, the top line, which is the solid blue, that a laparoscopic abdominal surgery has a higher associated survival in patients compared to, for example, the lower line in that graph, the dashed green line, which is open abdominal surgery. So you can see the difference there just visually between laparoscopic and open. And then in between are various other types of surgery. So cardiovascular surgery, open cardiovascular surgery, is the line just above open abdominal, as an example, as probably the next highest risk surgery in patients undergoing cirrhosis, in patients with decompensated cirrhosis. There are there are actually several scoring systems related to assessing risk in decompensated cirrhotic patients undergoing surgery. The two most common that you'll see is the Mayo Cirrhosis Surgical Risk Score and the Vocal Pen Score. There's been a bit of a shift in the last 2 to 3 years from using the Mayo score to using the Vocal Pen score, and I'll briefly go over these scoring systems. So the Mayo Cirrhosis Surgical Risk Score on the left is kind of what you would enter into the calculator if you look up this scoring system online. This was derived and published initially in 2007 from 722 patients with cirrhosis undergoing major digestive surgery, major orthopedic surgery, and major cardiovascular surgery. The issue with the Mayo Cirrhosis Surgical Risk Score is that despite an initial strong estimation of risk in this patient population, the calibration has degraded over time, and that's been data that's more recently been published, to the point that risk in these patients is actually overestimated in the modern surgical era. And this is actually shown in this graph here. So this is observed on the y-axis versus predicted on the X of risk of further decompensation in patients with cirrhosis undergoing surgery. And you can see the dashed line in the middle would be the ideal scenario where predicted equals observed. And as you can see, as the time has gone on, so you can see the solid lines represent different time periods. For example, the red is 2008 to 2010, all the way to the green, which is 2017 to 2019. That predicted risk has been straying from the observed risk. And so, like I said, the calibration has decreased over time. This has led to an additional scoring system being developed from a much larger data set of over 4,700 major surgeries in patients undergoing surgery, like I said, in decompensated cirrhotic. And they looked at a variety of surgery types: laparoscopic, abdominal, open abdominal, abdominal wall. That would be, for example, like an umbilical hernia repair, vascular surgery, major orthopedic surgery, and chest or cardiac surgery. And uniquely, this actually has been validated not only to predict 30, 90, and 180-day mortality, which you can see if you plug in these numbers on the left. So age, albumin, bilirubin, platelet, their BMI, whether or not they have metabolic dysfunction associated steatotic liver disease, whether it's an emergency surgery, and then the surgery type. And it gives you this data based on, again, population data, 30, 90-day, and 180-day mortality. It's also the only scoring system that then specifically predicts 90-day risk of decompensation as well. I want to point out at this point that no scoring system should substitute for clinical judgment. It's important to remember that these are tools to help guide shared decision-making between the medical team, the surgical team, and certainly the patient. And that these scoring systems are typically used to guide discussion or decision-making for elective surgeries. I did show that with the vocal pen score that there's one variable that you can enter, whether it's emergency or elective. I can tell you that if you just play around with that scoring system and put emergency for anything, the risk of decompensation and death are significantly higher for every surgical type. And that is not surprising. So there's an abundance of data showing that emergency surgery has a much higher mortality rate than elective surgery. I would typically use these tools for shared decision-making related to elective surgery. A common question we're asked in this moment would be, okay, well, we've discussed the risk of surgery. Should a patient with cirrhosis undergo a TIPS before surgery to lower their risk of surgical complications? Again, a TIPS, just as a reminder for everybody, is the placement of a stent which allows shunting of blood essentially around the liver. This is typically done, for example, for refractory ascites in some patients for early management of severe variceal hemorrhage and some other indications as well. So first of all, TIPS before non-hepatic surgery. Well, there's few data, and none, by the way, emerging from randomized controlled trials existing to confirm a benefit or to risk stratify patients with portal hypertension. Okay, so there's no data to support this from a randomized controlled trial. There was a retrospective propensity match study that included a very small number of patients with preoperative TIPS undergoing visceral and non-visceral operation that identified a reduction of acute on chronic liver failure and death within 90 days of the operation. But guidelines, and again, this guidance in the box here, just based on data, was worded that preoperative TIPS can be considered on a case-by-case basis after careful consideration of potential surgical benefits, but it's not something that is recommended as a routine procedure by any means. Recall that, as I mentioned earlier, the MELD score was developed to predict mortality post-TIPS. And so if TIPS is being considered, certainly the MELD score should be used to risk stratify. What we do and what most liver transplant centers would do in the modern era of management of these conditions is we would suggest first considering a liver transplant evaluation unless there's an obvious contraindication not to do so prior to a TIPS and or a non-hepatic surgery, especially if the MELD is consistently over 12 to 15. And that is because, as we've discussed, the MELD score higher than that number is going to be associated with increased risk of decompensation, certainly with a TIPS. And if that were to happen after an elective surgery and the patient has not been evaluated for liver transplant, these patients can quickly go into liver failure and become too sick to even be considered as a liver transplant candidate. Additional management considerations that I do want to mention, because surgical risk in a cirrhotic patient is not just about, plugging in these numbers into a calculator and saying, well, there's this risk or that risk. There are, in reality, obviously many other issues to manage. Not on this list would be just, for example, management of ascites prior to a hernia repair, for example. Here on the list, I put nutritional optimization. Certainly that's important for management of our cirrhotic patients in general. But in the setting of surgery would mitigate risk from malnutrition, sarcopenia, and frailty. As we've mentioned, there's no established thresholds for labs related to bleeding or clotting. We talked about thromboelastography, so considering that as a guide to decide whether or not there is benefit in targeting areas of the coagulation cascade for prophylactic transfusion. And though easier said than done, if possible, performing the surgery in an experienced center and selecting the simplest surgery would certainly be the recommended approach for these very sick, often and complex patients. I want to just highlight our team. I'm really proud to work with all of the individuals on this page here, but I want to note that there are many that are not on this page. Our nursing staff, our coordinators, our surgeons, and many others. This is our group of hepatologists, advanced practice providers, and liver transplant advanced practice providers. I think that we have a wonderful group here, and a group in which I trained, and then now obviously on faculty. And I want to emphasize that we want to be accessible to all of you who are listening from outside the UC Health system. Certainly, I'll share my contact information here in a second, but we want to be able to help your patients as much as possible. I put a QR code on there in terms of an easy way to refer patients for liver transplant. There's the QR code as on the screen, but also the fax number listed there as well, the 720-848-2246 number. We do our best to take care of patients, not just in the Denver area, but throughout Colorado. And in fact, throughout the Mountain Time Zone, extending from essentially the Canadian border to the Mexican border, going up to Billings, Montana, Albuquerque, New Mexico. And I feel fortunate that we were able to take care of patients in all of these locations. We've talked a little bit about liver transplant. I do want to share our data. The people that I mentioned earlier, the faces you saw are a big part of what has been a growing liver transplant program over the last many years. We set a program record actually in 2023 with 141 liver transplants. You can see there in the red bars. And so we want to help patients as much as possible. And if you feel like we can, please don't hesitate to reach out. We do have a 24/7 doc line with attending hepatologist to discuss complicated inpatient questions, including possibility of transferring patients. And that number is there. I put the fax number again, as well as the phone number for referrals, not just for transplant, but for hepatology clinic as well. And that's my cell phone, as well as my email address. And you're certainly welcome to reach out to me personally anytime. Thank you again for your attention, and I'm happy to take questions. I see that there's a few in the chat and Q&A, but if you have a question and haven't had a chance to type that in yet, please do so now. And with the time left, I'll try to tackle whatever questions come at me. While I'm doing that, I want to just share this slide as well regarding not only, I mentioned earlier, our webinar series for the rest of the year, but we also are doing a conference here in person on our campus in the beautiful building you see in the slide there, the Donald Elliman Conference Center, or Anschutz Health Sciences Building here on our campus. We're almost finalized with the agenda. It's going to be on August 10th, various GI and hepatology topics. And so hope to see many of you there as well. The registration for that is free. Okay. Let's see. So yeah, and again, while we're wrapping up here and while I'm answering questions, Lindsay has put the links for claiming CME and nursing credit, as well as more information in the webinar chat. So just going to the Q&A here. All right. Well, I see several familiar faces or names, I should say, on the chat. So thanks, and in the participant list. So thanks to all of you for listening today. I do want to just say that many of the people I see as listening live here today are currently in the state of New Mexico. I go down to Albuquerque, New Mexico twice a month to do an outreach clinic there. And our post-transplant EPPs that I shared earlier also go down monthly to do post-transplant clinic there. And I do want to just mention that we really enjoy coming down to New Mexico and taking care of so many of your patients. The same certainly goes for going up to Montana. All right, let me answer some of these questions. So just to consolidate, it looks like there are a couple of questions regarding beta blockers. So there's one that says, are you using carvedilol for those with clinically significant portal hypertension in compensated patients to prevent decompensation? And Dr. Jakish in Albuquerque asked the same question. Could you please comment on giving carvedilol for patients with compensated cirrhosis, even in patients with varices, to reduce the risk of decompensation? Yeah, so great questions regarding beta blockers. What I would say is that this has been an evolving topic in hepatology for many years. And the pendulum has kind of swung back and forth. Historically, the best data for a beta blocker would be for either primary prophylaxis of large varices, so large varices seen endoscopically. Again, not small varices, and we know that beta blockers don't prevent the formation of varices to begin with. But if you have large varices and have not bled, there's data for primary prophylaxis. There's certainly the best data for secondary prophylaxis. So if patients have bled from varices before, in addition to eradicating them endoscopically, starting a beta blocker, a non-selective beta blocker, targeting a heart rate of 55 to 60 roughly lowers the risk of bleeding. In patients with compensated cirrhosis without varices, there's more data now that would suggest. Now, it's not really made its way fully into guidelines internationally yet, but there is data to suggest that beta blockers may prevent initial decompensation. I would say that it's not part of common clinical practice at this point, but that would be an area that we're monitoring and may change our practice in the coming years. The concern with beta blockers, or one concern with beta blockers, in addition to the side effects in the past, has been, well, if patients have recurrent AKIs, refractory ascites, do the beta blockers blunt the cardiac output that tries to combat that vicious cycle that can occur in hepatorenal syndrome? Certainly in the setting of a severe AKI or refractory ascites, holding the beta blocker in that situation is appropriate. Although data would suggest that if the patient recovers from the AKI and the ascites can be medically controlled, that resuming the beta blocker has mortality benefit. All right. If patients are anticoagulated for a portal vein thrombosis, how do you manage anticoagulants in the peri-procedure time? Yeah, great question, Dr. Carrera. Thanks for asking. So in terms of, generally speaking, for patients on anticoagulation, for any indication, minimal interruptions of that anticoagulant are important. However, it depends on kind of what you sort of anticipate doing, honestly. So if you're anticipating a likely needing to band varices, then holding the anticoagulant for example, well, I guess it depends on the anticoagulant. Obviously, where there's warfarin, there's the direct oral anticoagulants, but holding the anticoagulant for anywhere from usually 2 to 5 days, usually on the shorter end, honestly, is appropriate for a procedure where you're going to be intervening, including band ligation, including a polypectomy for a colonoscopy. So we do typically hold anticoagulants in that setting and then resume them as able afterwards, as long as it's felt safe based on whatever was done during the procedure. It's not recommended. Just as this is a bit of a different question, but we're often asked if patients should get an EGD to evaluate their varices prior to starting an anticoagulant. And while that is commonly done in clinical practice, actually the guidelines say that you don't have to do that. So there's no data to support doing that. So you can start an anticoagulant in patients with cirrhosis without first looking at their varices. Obviously, if they had a variceal bleed a week ago, that would be a different scenario. But generally speaking, you can start the anticoagulant. Next question is, can you comment on your personal use of platelet-riding medications or L-Trombopag prior to elective banding of esophageal varices? Yeah, so I anticipated that someone might ask that question. Thank you, Dr. Cesario. You may be able, I'm not sure if, let's see. Um, Give me 1 second here. So I actually had the guidelines pulled up here because this is addressed in the most recent ASLD guidelines. And these medications, so you can, if you can see what I'm sharing here, I'm referring to this paragraph, and I'm just putting this on here because uh, I think it's easier to see while I also explain it. So these medications, which are TPO, thrombopoietin receptor agonists, and therefore increase the number of platelets. Um, Nowadays, most commonly, as you can see in the middle of this slide, avatrombopag and lusotrombopag are indicated for and have FDA-approved indications for the treatment of thrombocytopenia in adult patients with chronic liver disease. Um, it uh, it's important to know, I guess, two things. One is that while they certainly achieve a target platelet count over 50,000. There's actually no statistical differences in post-procedural bleeding events or what's the worry with these medications, thrombotic complications. So even though you can get their platelets over 50,000, there's been no shown benefit in actually reaching that goal, decreasing the post-procedural bleeding events. And therefore, the guidelines do not recommend routine use of these agents to prevent procedure-related bleeding. It's also worth noting that practically for these, you need to take them for several days, up to 7 or 8 days before the scheduled procedure, which sometimes is not practical, depending on whatever the procedure is that you're pursuing. So great question. Thank you, Dr. Cesario. Dr. Lazada down in New Mexico uh, has asked a couple of questions here. So she says, so Dr. Lozada, thanks for listening. Appreciate you being on here as always. So how much ascites is needed to be considered decompensated? Some criteria say overt ascites. What does that mean in practice? Can one have mild ascites or trace on ultrasound and still be considered compensated? It's a great question. I mean, I think that I would say that if um, there's a couple of ways to approach that. If you know what their transhepatic gradient is, if they've had a transjugular liver biopsy and it's over 10, so consistent with clinically significant portal hypertension, and they have even slight ascites, I would consider that decompensated. Now, in in practicality, most of these patients probably haven't had a transjugular liver biopsy. And so what I would say is that if they have small ascites that's read on an ultrasound, say they're getting an ultrasound for HCC screening, as all these patients should every 6 months, and it's noted that they have small ascites, but the patient has never complained of abdominal distension. They have no edema. They have no other clinical signs of portal hypertension. I would use the whole context of the patient in that situation and say that the patient is still clinically compensated. Overt ascites would be symptomatic ascites. They note abdominal distension. They're requiring treatment for it with diuretics. And so the short answer is yes, someone could have small ascites and be considered clinically compensated, but certainly it's more nuanced than that. Given what you showed about TEG, this is from Dr. Lazad as well, is there a role for KPA or vibration-controlled transient elastography, sort of commonly known as the FibroScan, to risk stratify patients' risk of procedural or surgical complications? So does a higher KPA have a higher risk of complications? So this is an excellent question. So we do know that there's data that higher KPA or the elasticity score on a FibroScan or vibration-controlled transient elastography is associated with greater degree of portal hypertension. So not only is it associated with a greater degree of fibrosis, but it's probably related to a greater degree of portal hypertension as well. There's data suggesting that. It's not been studied to risk stratify patients in the setting of procedures or surgeries, but I think that it's a really excellent question and maybe something that would be considered since as fiber scans are becoming certainly a lot more widely available, which I think is great. Dr. Cesario and Dr. Krishnan are asking if TAG is available through UC Health. Yes, it is. It's used pretty commonly at this point by us for thinking about pre-procedural bleeding risk in these patients. It's certainly used in the operating room most commonly. So yes, it is available through UC Health. And let's see. Dr. Jakish, thanks for your second question. Do you recommend giving octreotide drip prior and during surgery in patients with significant portal hypertension or large esophageal varices? Great question. I don't think I can recommend it based on data or guidelines by any means. I think that, if you're thinking about the physiology of portal hypertension, you could theorize that maybe it would at least transiently improve. But no, if I wouldn't recommend it as a routine procedure by any means. Certainly, it would be indicated in the setting of a variceal hemorrhage, and octreotide is often used in the management of hepatorenal syndrome. I know you know that already, but specifically prior to surgery, unless they've had bleeding varices, I would not recommend it in patients with even known varices or portal hypertension. Okay, we're nearing 1 o'clock. I just want to say again, thank you very much for making yourselves available in the middle of the day on the lunch hour. This video will be saved, so feel free to send it to your colleagues. And if you're watching it in the future, thanks for doing so. This again is the slide for the Rocky Mountain Highlights course in August 10th, 2024. Again, this information is on the webinar website, which you probably have since you signed up for this webinar. But if you don't, you can just actually Google UC Health Hepatology webinar series, and it'll be the first thing that comes up. And this information for evaluations is there. That's the QR code to fill out the evaluation and get the CME. And again, Lindsay, thank you for putting that information in the chat. And then this is the nursing credit information as well. All right. Well, thank you very much for your time, and I hope everybody has a wonderful day. We look forward to seeing you again with the next talk in our webinar series, which I'll close by putting on the slide here, which is May 15th, and that's updates in liver donation and liver transplant surgery, and that's by Dr. Baba Baikoff. Thank you very much again.